Hello class, I'm going to start with the concept of oxygenation, and then our exemplar for this will be pneumonia. We're going to start talking about some of the disease processes. Just want to go over this PowerPoint with you related to oxygenation. Please, just to remind you to watch the YouTube video that was advised for you to watch, that's in your weekly lesson plan. And then again, to remember about the normal anatomy and physiology of the respiratory system. We went over that in quite a bit of detail in Nursing 100. And again, you can reread that in your Pearson book, just to kind of refresh your memory about the various structures and what their functions are in regards to oxygenation and diffusion of gases. Because when we talk about pneumonia in a few minutes, it will make a lot of sense. Because when we really do talk about some of these disease processes, you have to kind of think about where is the problem happening at? What structure of the respiratory system are we seeing the abnormalities occurring in? Okay, so let's talk about oxygenation. Oxygen, it measures approximately 21% in the Earth's atmosphere. Each cell of the human body uses oxygen to metabolize nutrients and produce energy. And this is one element of our atmosphere that we cannot be without too long, where a person may develop anoxia or a lack of oxygen, where we start to see cells and organs quickly die. And without oxygen, cell death occurs rapidly. That's why whenever there's any compromise of oxygen due to some problem or pathophysiology that a patient is experiencing, it's important to be sure that we are providing the maximum amount of oxygen to be sure that all these cells and organs are functioning properly. So here's a good thing to start with as far as a question. Is the following statement true or false? Expiration creates more chest space, causing the pressure within the lungs to fall below that in the atmosphere. Think about it. Sit there in front of your computer screen and breathe out or expire, and see if you can answer that question by taking a deep breath out. And the answer is false. Inhalation creates more chest space, causing the pressure within the lungs to fall below that in the atmosphere. Okay, and it makes sense. Think about it when you take in a deep breath as opposed to when you blow out that air. All right, so let's look at the anatomy and physiology of breathing. Inspiration and expiration. Ventilation is that movement of air in and out of lungs, facilitates respiration. And respiration is that exchange of oxygen and carbon dioxide. And there's external and internal respiration. External respiration takes place at most distal point in the airway, and that's in that alveoli space between that alveoli capillary membranes. And internal respiration occurs at the cellular level between hemoglobin and body cells. So very important to know, especially when we start talking about the disease processes. And obviously assessing oxygenation is what we went over quite thoroughly in Nursing 100. It is part of our physical assessment. As I've said many times, you can walk into a patient's room and do that 30-second visual assessment where you look at the patient and say, hey, how is he doing as far as his respiratory status? What's his color look like? How fast is he breathing? Can he talk to me without having any shortness of breath? All these can be determined in a very short time, and really does begin that assessment process of their respiratory function. And again, physically assessing the patients, monitoring the patient's respiratory rate. What's the normal for that particular age group of that patient? We went over that a lot in Nursing 100, where, the respiratory rate of a baby or an infant is quite a bit higher than it is for an adult. Observe their breathing pattern and effort. Do you see asymmetry or symmetry? Are both sides of the chest rising and falling? Are we seeing just extreme shortness of breath? And again, then we take that stethoscope and we also take the lungs. Do we hear adventitious breath sounds? Or do we hear diminished breath sounds? Do we hear no breath sounds? Very important to definitely keep an eye on auscultation, because patients who have certain, especially respiratory and cardiac problems, will definitely have changes that can occur very quickly, especially if we see their respiratory status change. If they start to develop shortness of breath, let's listen to those lungs and say, hey, I didn't hear crackles before, but now I do, or I can't hear any breath sounds in that right lower base, and I also don't see good rising of that chest. Maybe the patient has now developed a pneumothorax, where there's a collapse of a certain lobe or even the whole lung itself. Other ways in which we assess oxygenation is through pulse ox, and we're going to go over that when we talk about some of the diagnostic studies. Okay. Pulse ox, if you remember, is composed of a sensor and a microprocessor. It's a non-invasive transcutaneous technique for periodically or continuously monitoring the oxygen saturation of blood. And what happens with that is it's a clip or an adhesive device that has a probe that analyzes the blood as it perfuses past the view of the two opposing sensors of the probe. Usually what we like to see that expected SaO2 values in a healthy individual who has absolutely no alterations in their respiratory function, we like to see it greater than 95%. When it's below that, we have to kind of take a look and see what's going on with our patients. Another way in which we can definitely promote oxygenation is by positioning. And when we look at Fowler's position, remember, it can be provided for the patient in several variations. We can be more specific when it comes to Fowler's position, meaning that we may elevate the patient's head of the bed in a high Fowler's position, where the patient's head is elevated at 80 to 90 degrees. And in a standard Fowler's position, usually that's about 45 to 60 degrees. And in a semi-Fowler's position, that's usually the head is a little lower at a 30 to 45 degrees. Many times we may use high Fowler's position used when we feed a patient who may be on feeding precautions, or when we're trying to deliver a respiratory treatment. A lot of times Fowler's position may be used to increase comfort while the patient is eating, or when maybe he's using his incentive spirometry. When they are in semi-Fowler's position, it may be used for a patient who's receiving tube feedings or to decrease the risk of aspiration. And your book gives a nice picture of these positions on 1035 in your Pearson book as well. Okay. And we also teach our patients about various breathing techniques that may help our patients to better oxygenate. When our patients do breathing techniques such as deep breathing, it really has an influence on their respiratory status. When we look at deep breathing exercises, and we also may know those as either diaphragmatic or abdominal breathing. And what happens is when the patient really demonstrates diaphragmatic breathing, it's when that breathing happens where the diaphragm actually forces down when it contracts, which in turn causes the abdomen to expand. And with this, you see negative pressure causes within the chest, forcing air into the lungs while also pulling blood into the chest, and therefore it improves venous return. So it will affect preload as well. And a good way to teach patients about these types of deep breathing exercises are to tell the individual to place one hand on their chest and the other hand on their abdomen and then take a deep breath. And to ensure that that diaphragm is pulling air into the base of each lung, the hand on the abdomen should rise higher than the hand on the chest. And that will kind of prove to the person that they are doing those exercises correctly. And depress the abdomen while exhaling through the mouth to ensure that all air is being expelled. And this is something, as your book talks about, it does take time and repetition to kind of train your body into this technique of deep breathing. So we should encourage the patient to do this several times a day. Okay? Another thing that we provide our patients is oxygen. Okay, oxygen therapy. And as you can see from the pictures here on the slide, most of us are familiar with the wall outlets where you see a flow meter. If the patients leave their rooms, a lot of times we can put them on oxygen via a portable tank. Then that device or unit on the lower right-hand side of the picture is a liquid oxygen unit or oxygen concentrator where it pulls the air from the atmosphere, and this is how we also can provide oxygen to our patients. We see this a lot with our patients when they go home on oxygen, and my mother-in-law had that particular type of a unit with her COPD and her pulmonary fibrosis as well. So those are different sources of oxygen that we can provide our patients, okay? And also you see here oxygen used, equipment used in oxygen administration. Obviously the flow meter that I showed you in the prior film, or the prior slide, and then there's an oxygen analyzer. And then on the right here, you see these disposable bottles of sterile water, and this is to provide humidity to your patients, especially if their oxygen flow rate is usually above 4 liters. Sometimes that can be very drying to the mucous membranes in the nares, especially if they're on a nasal cannula. So we will hook this particular device up to the flow meter, and you can see it just kind of screws in to the bottom portion of the flow meter, and then it will bubble as the flow meter is adjusted and provide humidity and kind of moisten up those mucous membranes so they don't dry out too much. Now remember, when we provide oxygen to our patients, it's definitely not a cure, but it can augment their SaPO2s, especially improve their levels of oxygen, especially when they're in their early stages of their exacerbation of the problem that they came into the hospital with. It's not that they always need it continuously, but it may be very beneficial in the first few days of how we treat these patients when they come in respiratory distress. And how do we determine if our patients do need oxygen? It might be indicated by their pulse ox, or just how the patient presents, or even from their arterial blood gas results. And we're going to go over blood gases in just a few minutes, but that's a very, very precise and indicative way of knowing if our patients are being oxygenated enough and not what we call hypoxic or showing signs of hypoxemia. There's many different types of a variety of oxygen that we can provide to our patients, and it just depends on how hypoxic they are and how much assistance they need to get their PaO2s up more than what is actually occurring. And obviously, respiratory therapy plays a great part in helping us set up these systems to provide that particular percentage of oxygen to our patients. And then we as the nurses need to make sure that it's maintained, even though the respiratory therapist may be periodically making rounds to be sure that that particular oxygen device is being delivered in the correct way and that the patient is tolerating the device as well. Probably the most common type of oxygen delivery system that we provide to our patients is the nasal cannula, and seems to be the most comfortable device in which our patients tolerates it very well. And you'll see a lot of our patients with severe respiratory problems tolerate it as well because they don't feel very claustrophobic with it. If you've ever cared for a patient with like COPD, you'll notice that many of them do not tolerate masks because it's just on their face and it feels very claustrophobic for them. The nasal cannula can deliver rates anywhere from 2 to 6 liters and can administer up to 44% oxygen to the patient at 6 liters. It's a low flow type of oxygen, and you'll see it provided to a patient during a particular procedure, maybe during post-op when the patients go back to the PACU when they're recovering from surgery. You'll see oxygen put on a patient just to hopefully deliver as much oxygen as possible, especially when the patient is waking up from a general anesthesia, because they're obviously not breathing really, really deep. So you'll see a nasal cannula on a patient temporarily from that. Nurses can pretty much hook up a nasal cannula for a patient without too much difficulty. I think we're all pretty familiar with that. But anytime there's any question of how to provide these delivery systems, call the experts such as respiratory therapy. My concern is when I come in to take care of a patient and I notice that a patient does have oxygen on, I always go around the bed and make sure I check that flow meter to make sure that it's being delivered as to what the order says. If it's supposed to be at 2 liters, 3 liters, I make sure I put that on the patient as well. I always get concerned when I see patients are supposed to be having this particular device and the oxygen may be lying in the bed. Ask the patient why they took it off, because the doctor has ordered it. If the patient refuses it, I would chart that accordingly and relay that information to the physician. If it's truly affecting their pulse ox and their O2 sats are really dropping, you need to educate the patients about the necessity of keeping that nasal cannula on. You always want to be sure that the nasal cannula, along with these other devices such as masks, are properly fitting the patient. They're not put on too tight, they're not causing skin breakdown, and to make sure that they're put on the patient correctly. I've seen the prongs provided to the patient incorrectly, where they can actually dig into the nares and cause irritation and breakdown. So you want to make sure that things are not too tight, especially on your patients, your elderly patients who might have a little bit more of a fragile skin. You just want to be sure that it's not on too tight, that you can cause skin breakdown. Sometimes you can put a little 4x4 underneath that tubing so it isn't so irritating and erosive to the skin there as well. Again, one of the most common types of oxygen delivery systems we have is the low flow nasal cannula. The next one we see here is the mask. We have simple mask, partial rebreathers, non-rebreathers, and Venturi mask. All right. This is a device that obviously, with it being a mask, will cover both the mouth and the nose. It is fitted to the patient's individual size of their face, okay? And these are ways in which we can administer a little higher concentration of oxygen if the patient needs, because, as I said before, your nasal cannula, even at the highest at 6 liters, will only provide 44% oxygen delivery. The flow rates can be much higher, anywhere from 5 liters to 8 liters, and the delivery from some of these can be up to 40 to 50%, and some of them can even go as high as 60% and up as high as 90%. You will get a better idea of these types of oxygen delivery devices when you have lab, because we actually bring all these devices into the lab and let you look at them so you're more familiar with them. Now, we don't use these as often as we do the nasal cannula, so it's important that when these are ordered for our patients, that respiratory comes in and sets up the device, because we don't usually have these masks in stock on the units, and so respiratory will come up and put the patient on these and really do some teaching with the patients about why it's so important that the patient keep it on. Now, obviously, with it covering both nose and mouth, the patients can take those off during mealtime and put on a nasal cannula temporarily, but after meals they should then resume the mask that was ordered for the patient, so they get the full benefit of that higher percentage of oxygen. Many times when we convert over to a mask, it's probably because the patient's SATs were decreasing, or the patient was having more respiratory difficulties, or their PaO2s were low according to their blood gas results. So many times you'll see patients, if we're changing the oxygen modality, they'll have further blood gases ordered to see how the patient does respond to these different types of oxygen delivery systems. So maybe we'll put them on a simple mask or a partial rebreather and get blood gases in 1 hour. So make sure that when we get those blood gases, that the patient has had that particular device on for that whole hour, and the patient hasn't been taking it off and putting it on, because you're not going to get the true indication of how that devices work for the patient if the patient is not keeping it on the whole time, or it keeps taking it off. Now, your Venturi mask is a high flow type of oxygen delivery system, and that can really provide precise concentrations of oxygen. And let me show you those, and I think they're in the next picture. Okay. This is a table I want you to see as well. You can see exactly how much oxygen can be provided with nasal cannula depending on the flow rate. You can see they get up to 44-45% FiO2 delivered. Simple face masks, we can provide up to 60% FiO2 at 10 liters per minute. And then you can see a non-breather mask can provide up to 80 to 100 percentage of FiO2, and then your Venturi mask is indicated for precise titration of percentage of oxygen. Flow rate can be anywhere from 4 to 8 liters, can deliver as much as 24 to 60%, and usually there's this little like disc that is color coded, and depending on the color will determine the percentage of FiO2 that's delivered. Let me see if I can show you that in the next slide. Yes, they're in this slide. As you can see, on the far left is a nasal cannula, and then these are the types of little disc or attachments for a Venturi mask. You can see they're all color coded, and actually on that particular attachment, it'll tell you how much oxygen is being delivered. It really can give that precise amount, and it is one of our high flow common types of delivery devices. And you can see these are varying types of masks that we may see put on a patient, especially if they're hypoxic or not responding very well to the nasal cannula. People with lung diseases and heart diseases can go on to be discharged with your nasal cannula, okay? And you just want to make sure that the device is clean of any obstructions and that it is definitely applied to the patient in the correct way, okay? All right, so that's oxygen therapy. And these are other additional delivery devices, oxygen tent and CPAP. CPAP you might see on a patient who has various problems, especially during nighttime when they sleep. We see this for an indication of sleep apnea, transtracheal oxygen, and then again, if patients are going home on oxygen, we really need to explain good homegoing instructions as to oxygen hazards and the potential for fire potential, and then of course oxygen toxicity. And what do we mean by that? Usually patients who receive high levels of oxygen can cause oxygen toxicity. I'm not going to get into a lot of details, but you might see patients develop respiratory problems because of it. That's why when we learn from a report that our patient's been on a high level of oxygen for more than 1 or 2 days, it can actually start destroying the lungs. And patients may develop what we call adult respiratory distress syndrome, and it may not then be so beneficial. So that's why when they're on high doses of oxygen, that really tells us that the patient has a very, very serious diffusion problem. And what you might see happen is in the beginning, if they're developing oxygen toxicity, they might start to have like a very subtle, non-productive cough, particularly if they hadn't been coughing prior to that. So it's just something to think about, because we want the oxygen to be beneficial to them and not harm the patient. So we want to keep an eye on that FiO2 and how much oxygen we are delivering to our patient to avoid the potential problems that we see with too much oxygen given to the patient in over a long period of time. And here's administering oxygen safely. Usually there should be signs indicating that oxygen is in use, and when people go home with oxygen, you want to make sure that they're not burning candles, and which could cause a fire. Any type of electrical devices that have 3-prong plugs could be a ground for leaking electricity. Anytime there's an area with frayed wires or loose connections, can be a source of a fire. Avoid using petroleum products, aerosol products, such as hairsprays and products that contain acetone, especially if women are doing their own nails. It could prevent ignition of flammable substances. And make sure when you have portable oxygen tanks that they're in a proper container. They're not just leaned up against the wall. You don't want those to fall and have that particular tank rupture or crack or break open. Okay. Think about our elderly patients, the gerontologic consideration, reduced gas exchange and efficiency and ventilation. Major age-related changes occur in the respiratory system. Respiratory muscles become weaker and the chest wall becomes stiffer as a result of calcification of the intercostal cartilages. These are some of the normal aging changes that we see within the respiratory system. Okay. And again, if you remember, they also have diminished cough and gag reflexes, increased use of accessory muscles for breathing, increased mouth breathing, snoring, and inactive, debilitated, or chronically ill clients or smokers are at higher risk for respiratory infections and compromised respiratory function. That's why a lot of these patients are at risk for pneumonia, and we truly recommend that they get the pneumonia vaccine to hopefully decrease the risk or incidence of getting pneumonia, which we're going to talk about in just a little bit. So that's just a recap of some of the important information from your reading. We're going to look at some of the diagnostic studies that we may see. This is, again, a very important system. It probably is the most important system because without proper oxygenation, you're going to have some very serious problems. And when those organs, such as the brain and the heart and the kidneys, are not perfused or oxygenated properly, you're going to see the patient begin to deteriorate very significantly. All right, so we'll move on to look at our first appendix. So get out Appendix 19, and we're going to talk about diagnostic testing for the respiratory system. All right, class, I'd like you to get out Appendix 19 from your weekly lesson plan, and let's go over these diagnostic studies and what do they tell us about our patients, and what can they actually diagnose with our patients as far as what precise respiratory problem do they see. Now we're going to get into a little bit more detail about arterial blood gases in just a few minutes, but this is a very, very important and very useful blood test. And remember that the blood sample comes from the arterial side of the system, okay? It provides a direct indication of oxygen and carbon dioxide exchange, and also talks about the pH of the blood as well. And the major chemical components monitored within ABGs are your hydrogen ions, your carbon dioxide, your oxygen, and of course your bicarbonate, which is known as HCO3. So we're going to look at those in just a few minutes and look at the levels of those as well. But we use this test a lot with our patients who have a history of COPD, patients who go into respiratory failure, patients who have renal disease, and especially our patients who are diabetic that might come in diabetic ketoacidosis. Plus we use it a lot when our patients might be on a ventilator where they might need assistance in breathing. Before we take them off the ventilator, we will wean them slowly and put them first on a T-piece, check their tidal volume, and then do a set of blood gases to make sure they're breathing enough on their own and they're oxygenating well enough and they're blowing off their CO2 as well. So those are other indications of why ABGs might be done. Or just the fact that you see a big change in the patient's condition. All of a sudden in the morning they were fine, but as the day went on, you noticed they were going into some respiratory distress, and their lungs sounded really junky. They might have developed adventitious breath sounds. Maybe you had a chest x-ray done on them per doctor's order, and now we're going to check ABGs and get precise measurements of those four components as I talked about: the hydrogen ions, the carbon dioxide, oxygen, and their bicarb levels. Okay, so and other times that we see ABGs ordered is maybe we're changing oxygen modalities or oxygen delivery systems. Maybe they've been on a cannula, and we move them to a simple face mask, and that's not working, and then we put them on a non-partial rebreather. Usually we'll put them on those oxygen devices for an hour and then repeat blood gases. So this is some very, very useful tool to determine, the treatment for these patients when they're having respiratory problems. Remember, when we talk about the SaO2, which we do measure with our pulse ox, that is the measure of the percentage of hemoglobin that is actually carrying the oxygen. And then that PaO2 that we get from arterial blood gases is the measure of the amount of oxygen that's dissolved in the arterial blood. And as I said before, that SaO2 should be 95% or higher. And then we look at carbon dioxide levels. Usually the normal range is anywhere from 35 to 45 millimeters of mercury. And remember those terms that we did talk about in Nursing 100 is an increase in blood levels of carbon dioxide above 45 milliliters of mercury is known to be what we call hypercarbia or hypercapnia. And by contrast, if the levels of carbon dioxide are below 35, then that is known as hypocarbia or hypocapnia. All right. So, and then remember, we're talking about two systems, the respiratory system and then, of course, the metabolic end of it, which is demonstrated about the kidneys' effectiveness. And the kidneys also play a big role in maintaining your body's acid-base balance. It has the capacity to excrete or absorb acids and bases, okay? So we look at that function of the kidneys through the bicarbonate levels as well. And remember, when we're talking about normal functioning of the respiratory and the renal system, we want to see the body maintain that level of homeostasis where there is equilibrium, okay? And so we'll get a little bit more into that. But those are arterial blood gases as well. And then we look at sputum. And we've talked about this in the past where, you know, if our patients are really bringing up a lot of sputum, we really should send that specimen down to the lab to have it analyzed and do a CNS or a culture and sensitivity to determine what organism is growing in the sputum. That will help the physician order the correct antibiotics. We see this a lot with respiratory infections, patients that have tuberculosis. We might also see cancerous cells in the sputum if the patients are suffering from, unfortunately, lung cancer as well. Then PFTs are pulmonary function test, and these demonstrate changes in the pulmonary system or the health of the individual. That's related to anything that has to do with ventilation, airflow, lung volume, and capacity, and also, of course, the diffusion of gases. They also do some intricate testing with pulmonary function. Why do we do pulmonary function? It can be a very intense test, which gives us pretty much the whole overview of how the lungs are functioning. You might see this ordered on a patient that's going to have a long process during their surgery to make sure that the patient is able to tolerate being under anesthesia that long. And so we want to get the full understanding of what this person's lung function is. So that's when pulmonary function testing might be done. We might see it done to actually diagnose a problem, and we usually can diagnose asthma through pulmonary function testing because it also incorporates spirometry, peak flow meters, and inspired and expired air, as well as the diffusion ability of the alveoli capillary membrane. So it really can be very tiring for a patient. But if you've never seen pulmonary function testing, I would really suggest that you go to that particular area of the hospital with your patients and kind of monitor and kind of witness a patient having PFTs done. All right, and we see this for asthma, COPD, patients with emphysema, patients with pulmonary fibrosis, or patients with sarcoidosis as well. Okay. Then we look at the chest X-ray. Usually what they'll do is an A&P chest X-ray, and it allows for two-dimensional visualization of what's inside the thoracic cavity, and this can give us a better knowledge of any fluids, any exudates, or any masses that are obviously present within the thoracic cavity. Your CT scans and your MRIs will provide more information about the structures within the thoracic cavity. We use chest x-rays a lot. Most patients who come into the hospital will have a chest x-ray done, and a lot of times we look at previous chest x-rays to do a lot of comparison. Has that changed drastically? Has the organs changed? For instance, the cardiac silhouette we can see on a chest x-ray. And as I said, it can really tell us a lot about atelectasis. It can help us diagnose pneumonia. It could help us with a patient who has had a pneumothorax where we see re-expansion of the lung. We can see masses, and if a pulmonary emboli is big enough, we can see it also on a chest x-ray, but obviously they're going to do further testing to make that specific and definite diagnosis. But, it's just a crude x-ray, but really can provide a lot of information. Another thing that we use chest x-rays for is placement of specific IV lines, particularly your central lines and your PICC lines. We also look at chest x-rays for placement of endotubes to make sure they're not into the right bronchus, that it's actually in the trachea, and as to what level it's at, so that it provides the best oxygenation for the patients. So chest x-rays are very, very helpful to the patient as well, okay? We can use it for pneumonia, as I said, cancer, asthma, pulmonary fibrosis. We can see if a patient has aspiration, broken ribs, fractured ribs, pneumothorax, and re-expansion of that lung after we put in a chest tube, and then of course invasive lines as well. The next one is a bronchoscopy, and we talked about that. That's that procedure that allows the direct visualization of the lungs, usually performed by an internal medicine guy or a pulmonologist, where they take a bronchoscope and it's inserted orally into the trachea, and it's advanced down in through the bronchioles to kind of get an overview of what's going on and what those structures look like. We use it for biopsies. We can instill medications. They might want to get into those bronchioles and suction out tenacious and thick mucus if the patient's unable to expectorate that mucus on their own. Obviously sedation is needed, because anytime you're putting a tube down into the lungs, you're going to have the patient cough, so they have to have sedation. So you want to make sure that when they return back to the room after a bronchoscopy, that they have their gag reflex before we allow them to drink or eat. And then, of course, to observe for possible post-procedure infection or a lot of bleeding or any respiratory distress. We use it for, obviously, aspiration, cancer, infections. We can make some very specific diagnoses with bronchoscopies. Thoracentesis is when they actually go into that pleural space. It can be both an intervention and a diagnostic test, and it can be used to drain that excessive pleural fluid from in between the pleural linings. And again, that particular fluid that they extract or drain from that pleural space is analyzed for many, many different things. Blood, fiber, microbe content as well. We can do this procedure in a patient's room. Usually the nurse is there to assist the patient to be sure that patient is not having any respiratory distress. I went over this a lot in Nursing 100. It's a sterile procedure. Usually they'll numb the area. A lot of times when it's a little bit unsure of where that pleural space is, they may bring x-ray into there and do this procedure under fluoroscopy, which avoids the doctor from hitting a lung or not getting into the correct space, because you want to make sure you're going into the pleural space. And a lot of our patients who develop what we call pleural effusion or excessive fluid in that space may be developing respiratory distress, so that's why the patient may have what we call a thoracentesis. So again, post-procedure, you want to be sure that the patient is not suffering from any respiratory distress, and that they're not coughing up any serious amount of blood, and make sure that we're auscultating breath sounds to make sure we hear them in all lobes, so that the patient hasn't developed what we call a pneumothorax. A lot of times these things, if they're going to happen, they're going to happen usually in the first 24 hours. Okay, so again, pleural effusion, cancers, infections are reasons why and how we can diagnose things with the patient, especially when that specimen is sent down. Usually we don't like to drain any more than 1,000 mLs because we're worried about mediastinal shifts, but we do see some patients who have copious amounts of fluid that really need as much drained as possible to help relieve a lot of their respiratory distress. VQ scans are to diagnose pulmonary emboli. And again, the V stands for ventilation, and it's pulmonary angiography, and pulmonary VQ scans demonstrate the ventilation and the perfusion activities of the respiratory system. Remember, a pulmonary angiogram is used to identify structural changes in the pulmonary vasculature, and that could be anywhere from a blood clot to a tumor, an aneurysm, or even an overinflated alveoli. And then a pulmonary ventilation scan, which is the VQ scan, uses radioactive isotopes to identify defects of ventilation and perfusion. And what they'll do is they'll inject those radioactive elements to help identify the defects of perfusion, whereas inhaled radioactive gas identifies defects of ventilation. So that's the unfortunate result of a pulmonary emboli that you may see, and so that's why we can see a VQ scan ordered for a patient if they're suspecting pulmonary emboli. And then, of course, MRIs and CTs, they both can cancer, pneumothoraxes, looking at the structures, tumors, things like that. So, and sometimes with CT scans, they will either do unenhanced or enhanced, and what do we mean by that is we can get better pictures if we give dye, but we have to evaluate the patient to see if they can tolerate the dye, because remember, a dye injected into the vasculature is pretty much a toxic substance, so we have to make sure that patients are able to tolerate that, and we look at kidney function as well, such as their creatinine levels. If it's too dangerous, that could put them in acute renal failure, we would just do an unenhanced CT scan, okay? And so remember, your CT produces cross-sectional images of the contents of the chest. It may be used with dye to determine the presence of pulmonary embolus. And remember, with MRIs, if they have any type of implanted metal devices, that would be contraindicated in using that type of a diagnostic study. So those are basically some of the most common and familiar type of diagnostic studies that we see with our patients to determine precisely what is their respiratory problem. You know, they come in, they're in distress, we see abnormal blood gases, they need oxygen, but we're not always sure what the etiology of their problem is. These tests can help us determine that, along with the physician, and the kinds of manifestations that's being presented by the patient. All right, so those are diagnostic studies, okay? So make sure you jot down little notes that I talked about. This is all in your book on page 1033 as well. All right, class, now we're going to look at ABGs, arterial blood gases. There is a video in your Canvas course under modules, week 4. And before we go on, I want you to be sure that you look at that video before we do these problems, okay? So you might want to stop this and be sure that you have viewed the video, the Pearson video on acid-base balance. We also want you to be sure that you do your reading in your Pearson book. It starts on page 3 and goes all the way through page 12, okay? You need to read this through, okay? I will be honest with you, we're just introducing you to arterial blood gases, and as we go over these problems, after I go over the PowerPoint with you, we're just going to talk about whether or not the patient is acidotic or alkalotic, or whether or not it's a respiratory or a metabolic problem. And when we talk about respiratory, it's pretty much saying that the problem stems from the fact that the patient has a respiratory problem. When we talk about metabolic, it usually signifies that the patients have some kind of renal problem. So that's how we can precisely say where the etiology of the problem is coming from, okay? We're not going to do any compensation, meaning the opposite system will help compensate, especially if our pHs are out of normal range. We're not going to do that in Nursing 121. You'll get compensation in Nursing 122. Right now we want you to understand those components, as I said, the hydrogen ions, the PaO2, the PCO2, and of course the bicarb, all right? Those components of blood gases. As you can see, the practice problems provide you with 3 values that are in arterial blood gases, and by having only those 3 values, we can determine is the problem metabolic or respiratory, and is it alkalotic or acidotic. So it is very important that you view the video from Pearson first, and then we'll go over the PowerPoint before we do these problems, okay? And that you do your reading from pages 3 through 12 in Volume 1 in your Pearson book. All right, here's an introduction to acid-base balance. And some of you may be a little familiar when we talk about acid-base balance, when we look at that at pH scale. When we see that 1 to 14, where 7 was neutral, and then anything below 7 was acidic, and anything above 7 was alkalotic. This is pretty much the same thing, but we're going to look at it in regards to a patient's status, in regards to their respiratory health and their renal health. So let's look at these terms when we talk about acid-base balance. Remember, acids contain hydrogen ions that can be released. Alkali or bases can't accept hydrogen ions. And when we talk about the pH, it's a measure of the concentration of these hydrogen ions, okay? And then there's buffers in our bloods, and that's chemical pairs that neutralize small changes in pH by combining with and releasing hydrogen ions. So that's where it all comes from, okay? When we talk about the pH of the blood, all right? All right, moving on. Now, how our pH in our blood is controlled is by 3 mechanisms in the body. The first one is the buffer system, all right? And your buffers are substances that will prevent those major changes in the pH by helping to release hydrogen ions. So, for instance, if there's excess acid present in body fluids, the buffers will bind with hydrogen ions to minimize the changes in the pH. And if the body fluids become too alkaline or too basic, they'll release hydrogen ions to help decrease that pH, okay? These buffers will act within a fraction of a second, but their capacity to maintain pH is very limited. The body's major buffer systems are the bicarbonate, carbonic acid buffer system, and the phosphate buffer system, and protein buffers, okay? And we'll get into the normal range of what those should be. And then, of course, we have the respiratory system and the brain's respiratory centers, and that regulates that carbonic acid by eliminating or retaining carbon dioxide. Remember, carbon dioxide is the acid, so that's when it's combined with water, what does it form? But carbonic acid, a volatile acid. So what do we see sometimes happen is we see an acute increase in carbon dioxide or hydrogen ions in the blood that stimulate the brain's respiratory system, and what it'll do is, as they see an increase in carbon dioxide, it'll stimulate that center in the brain, causing the person to increase the rate and depth of their respiration to help blow off that CO2 and bring those levels down, all right? This compensation for increased hydrogen ion concentration occurs within minutes, but it'll become less effective over time, especially with some of our patients that have chronic lung disease, such as COPD. For example, patients with chronic lung disease have consistently high carbon dioxide levels in their blood. And alkalosis, by contrast, will depress the respiratory center, decreasing both the rate and depth of respiration and causing you to retain carbon dioxide. And then we have the renal system, which we have up here in the screen, is responsible for long-term regulation of acid-base balance, and the kidneys normally eliminate the excess non-volatile acids produced during metabolism. But remember, the kidneys will help respond when the pH is out of whack if the respiratory system is the primary problem, but it reacts much slower than the lungs do. So although the kidneys respond more slowly to changes in the pH, anywhere from hours to days, they can generate bicarbonate and selectively excrete or retain those hydrogen ions, just depending on what that pH is, all right? So just wanted to make sure you understood these three systems, all right? And then, of course, as I said before, the respiratory center in the medulla responds to higher levels of carbon dioxide by stimulating the respiratory rate to increase in rate and depth. And then, of course, the renal regulation is where the kidneys excrete hydrogen ions and form bicarbonate. And here's where we actually, I'm not sure if I had that up there on the screen. Regulation respiratory center in medulla responds to higher levels of carbon dioxide by stimulating respiratory rate to increase in rate and depth. And of course, the renal regulation is kidneys excrete hydrogen ions and form bicarbonate. So here's actually what we're looking at now when we're talking about arterial blood gases. They provide a measure of the partial pressure of oxygen, partial pressure of carbon dioxide, and the ratio of hydrogen to bicarbonate. And these are their normal values, and I'm going to talk a little bit more about this in depth, okay? And a lot of the students will say, what range of bicarb should we use? Use whatever in your book, and that range is, I think, 22 to 26, all right? So that's what we use as our range for sodium bicarbonate, okay? So the pH normally in our arterial blood is 7.35 to, it's 7.45, sorry, this should not be a 4, this is a 7. As you can see, there is a very, very narrow range, so anytime that pH is out of that range, we're having a serious problem within our patients. And the normal range for your CO2 is 35 to 45 millimeters of mercury, and then your bicarb is 22 to 26. Okay, also millimeters of mercury. So, or no, that's milliequivalents. I'm sorry, I apologize for that. Milliequivalents per liter. Okay, that's how we label our bicarbonate levels. Okay. All right, we're going to talk more about these levels in just a minute, okay? when we talk about reviewing those problems. And as we review these problems, I just want to say that a good a good way to think about these is, let's talk about it in regards to a patient problem, and then it sometimes makes a little more sense. All right. So what we'll do is we'll look at the practice problems as well. I'm going to start a lecture for that.